So today we're going to talk about one of the 10 manual therapy techniques that every physical therapist should know, and that's the lumbopelvic regional manipulation. And this is one of the manipulation techniques actually that has a really good evidence base for it. John Childs, Julie Whitman, and company put together a couple of studies actually, and they came up with a clinical prediction rule of 5 things that you look for when examining the low back that tells you whether this manipulation is going to work or not. Do you recall the 5 things they look for?
I believe it was symptoms less than 16 days, no symptoms distal to the knee, FABQ score less than 19, 1 lumbar hypomobile segment, and 1 hip internal rotation greater than 35.
Yeah, exactly. And that all points to iliosacral pelvic girdle dysfunction. So this is largely a pelvic girdle manipulation. Now the reason it's called lumbopelvic is that in the setup you're looking for the SI joint to cavitate. But very often the lumbar spine goes, and that often gives relief too. So we're aiming for the pelvis, but if we get the lumbar spine and we get relief, hey, why not kind of thing. Now, to my mind, the use of this manipulation, in addition to the 5 clinical prediction rule findings, is that you're assuming pelvic girdle dysfunction. And this one, mostly to my mind, goes for iliosacral rotation, an anterior innominate, a posterior innominate. It might fix a sacral torsion as well, but I tend to think of this as an iliosacral technique. So you've already done your exam through bony landmark type things, leg length differences, rotation, all that's out of the way, and you've decided that it's either a left or right hypomobility, which is how we always begin our diagnosis, then is it a posterior innominate or a anterior innominate? We can talk about in flares, out flares, all that kind of stuff, but I tend to think in terms of anterior and posterior ilial rotations, okay? So you'll be our patient, and just for the sake of this demonstration, let's assume that through our exam we decide you have a left anterior innominate, okay? So let's have you lay on your back right here. I'm going to adjust the table a little bit. And you always treat with what you assume to be the anterior rotation away from you and the posterior rotation near to you. One thing we want to do is get rid of any movement in the lumbar spine, again trying to focus on the pelvic girdle. So the first thing we're going to do is side bend you away from the practitioner. And I like to put the legs to the side. I always put the distal one on top, the ankles right here. That kind of maintains this position. I bring your pelvis over this way. For the classic technique, you're going to lace your fingers behind your hands. And I'm going to side bend you. Okay, so we side bend away. And how does that feel?
That feels comfortable enough that I'm taking up all the component motions.
Okay, and just using Freya's laws, if we side bend left and rotate right, we're going to lock up the lumbar spine to the extent that we can. The trick to this is to maintain the side bend. So what I do is take you into further side bend, and then I put my fingertips into the table. And that way when I roll you, my fingertips in the table maintain that side bend, okay? And how does that feel?
That feels comfortable.
Good. Now I'm going to take up more of the slack until I see the ilium rise, and that still feels okay?
Yeah.
Good. I'm going to put pressure here. This is our pre-manipulative hold. How does that feel?
Feels comfortable.
Good. I take up more slack, and then we give a push, okay?
All right.
And that should be it. Now again, this is designed to correct a left anterior, and it kind of makes sense because I'm pushing posteriorly.
Right.
What's harder to appreciate is that when I roll you this way, you get a ground reaction force between the table and the right ilium pushing it into an anterior direction. So this also fixes a right posterior. So this fixes a left anterior or right posterior. So you can actually have your diagnosis wrong, but still get the treatment right. Okay? And that's basically it. That's the lumbopelvic regional manipulation. I find it works very well, especially when those 5 clinical prediction rules are lining up for you.
Right, perfect.
Good.
All right, thank you.